Good evening, everybody. Welcome tonight. Glad you can make it. I see a few new faces, so welcome to all the people who are new, and glad you can make it tonight. My name is Kobe, and the leader here in this group. And tonight we're going to be talking about medical stuff. We'll get into that here in just a minute. We are next month going to be talking about bug in or bug out. You know, what's the best choice for you, and when to determine when to go, and those types of things. We're going to be talking about designing a shelter, and we're going to be talking about buying a property. If you're think you're in the market or might be in the market for a property, what are some characteristics that you want to look for? And I will tell you this, there's probably not the perfect property out there, but there's certainly some things that I would say you definitely want this and you definitely don't want that. And you kind of do your checklist and try to find what is best for you. But we're going to talk about all that next month. Then in March, Alan, over there in Coffee Line, we're back to communications. And that was the most requested topic. When I passed out a few months ago the list and everybody wrote down what topics you wanted, radios and communications was our #1 requested subject. So that is coming up in March. And I know we had previously scheduled that for, I think, November, and then Alan wasn't able to make it then, so we pushed it to March. When we were talking about it happening in November, I know we had promoted the Baofeng radios that you could buy off Amazon that are a good, high level of, they have a lot of features, but they're cheap from China, but they're a good radio for preppers, and so a lot of people bought those in anticipation of being able to bring them, and Alan was going to program them with his computer. I think he's still going to do that in March, right, Alan? Okay. I put him on the spot here while he's fixing coffee. But that's coming up in March. Then in April and forward, I haven't yet determined what we're going to be doing. So I'm going to be taking suggestions. If there's something you would like to teach or something you would like to learn about, let me know. And we'll be happy to schedule those out the rest of the year. Also, you'll note on there, on your notes, talking about our bug out camp. Again, I really would encourage you, if you are at all available, to come to our bug out camp down at Roaring River State Park. It's in Cassville, which is about an hour and a half away. It is a great opportunity to sit around the campfire, to get to know your fellow like-minded individuals. And the cost, as far as we're concerned, is only $20. And that covers 2 meals, so pretty good there. You cover your own meals. You got to pay for your own campsite, but you reserve that through the state park system. And we just had a great time. We have people come up from Arkansas, the Northwest Arkansas group, and people come over from Tulsa, from the Tulsa group, and we all meet. And had a great time this last year, and look forward to that again. I would encourage you, if you have not yet reserved your campsite and you would think about going, for 1 night or 2 nights or all 3 nights, it doesn't really matter to me, but reserve your campsite now. You got to pay for it with your credit card, but then if you end up not being able to go, if you cancel within, I think, 24 hours or something, you get a refund of most of your money, so you're not out a lot. But I would encourage you, if you think you'd like to come to the Ozarks Bug Out Camp, go ahead and make those reservations for your campsite, and we would love to have you come. It's absolutely a great event. Any questions on any of that before we get going? There was a question on your notes there. You have a copy of the notes here real quick? There it is. Let me read the question. It says, what types of medical situations do you anticipate in the end of the world as we know it type situation? Infections that turn septic. There's a medical professional there. A lot of burns. Talking about alternate cooking methods, we're not used to cooking as much over a campfire or a gas stove that may soon be outlawed. I don't know. We won't get into politics here, but alternate cooking methods, or maybe just because of the event, whatever has happened, there may be burns too. So burns is good. Septic, some infections, that type of thing. What else would we anticipate?
That's from hatchets, knives, machetes.
Yeah. From manual labor. Absolutely. I think there's going to be a lot of sore backs and just sore muscles, but absolutely injuries, trauma in general from our instructor here, trauma in general, and I completely agree. Various types of trauma from working hard, doing things, tasks manually that we were not used to doing manually, but also from potential violence or the situation in general, whatever caused things to change.
161 million Americans are on medications that they probably will not have long.
Wow. Yeah. So you hear that? 161 million Americans who are on medications they will probably no longer have access to. That is absolutely going to be a huge factor in our medical situation. Absolutely. Good.
Low in supplies.
Low in supplies. Medical supplies, is that what you're talking about? Or low in just like food supplies or all the above?
Yeah.
Absolutely.
Yeah.
So we can see starvation, malnutrition. We could, all that type of thing. Long lost what? Plagues coming back up. Yeah, things that we thought were gone, diseases that are now coming back. Absolutely. Sprains and breaks. Yeah, absolutely. Again, tied to more manual work as well as manual transportation. If we're having to hike everywhere we go, sprains, breaks, those types of things, absolutely. GSW, gunshot wounds, absolutely. The violence aspect there, absolutely. Hypothermia, yeah. Or the other side of things, heat exhaustion. We'll no longer have air conditioning, most of us, and most of us are pretty accustomed to that. Good. Eating bad food, yes. No longer have refrigeration and freezing for the most part, and eating things that shouldn't be eating, or water, either one, waterborne illnesses, absolutely. These are great things, and absolutely what we want to talk about, because Carol is now going to give us the answers to all that. Absolutely. No, Carol and Mike are, I appreciate them very much. They have been very active in our group since we started over in the other locations, and I appreciate their faithfulness and their willingness to come and share their knowledge. If I was going to talk about emergency medical care, I don't know the two people that I know anywhere that rather than these two that I'd rather have come talk to us. And I appreciate them coming because not only do they know the medical stuff, but they also are true preparedness minded like we are, and so they can give us the information from that perspective. It's one thing to have a doctor come and talk to us who doesn't understand preparedness and he talks to us, but to have someone who has the credentials and also understands preparedness mindset. I appreciate Carol and Mike coming, so thank you guys.
First of all, can you all hear me? I don't want to blast everybody out, but I want you to be able to hear me. Thanks. Okay, so we've given you all a handout that we hope will be helpful to you. The things that you can search for on YouTube that are good learning sources. So EMT and paramedic preparation, the Peterson test prep, Rescue Randy, all of these YouTube channels have really good information about first aid from a professional standpoint. Also, there's Jace Medical. We've put some information here on what the emergency antibiotic kit it contains and how much it costs. We have some training resources for you, and then on the very back page, we have a lot of information. The majority of it is from the Urban Survival site, but there are some other sites too that are good for good information. We've looked through these sites and feel like they're pretty good information. One of the reasons that we feel like it's important for all of us to know what to do in an emergency is, I'm going to give you some information here about this. 25% of government budget is spent on health care. 75% of the hospitals in our nation receive the majority of their income, or 75% of most hospitals' income, that's for most of the hospitals in the nation, 75% of their income comes from the government in Medicare and Medicaid reimbursements. I don't know how long that's gonna last. 30-hour waits plus waits in their emergency departments, locally even, but all over the United States, there are huge, tremendous waits in ERs. So you may have something that's life-threatening. In Canada, there was a woman that was in her 30s yesterday who was in the waiting room with abdominal pain and died. That's happened here, guys. That's happened in Springfield. This is not uncommon. People come to the emergency room for help and die. And it's not just here. Ambulances take the majority of their patients that are being taken to the ER, taking them to triage. They're taking them to the waiting room because there is no room in the ER for them. They're either overpopulated with patients or they're understaffed, and both causes. Many times you have to wait. We had a friend that was trying to make a doctor's appointment, and it was going to take him 2 months to get in for just a general doctor's appointment. And that just tells us that our healthcare system is failing. So what happens if you take care of someone who's not your family, just, you come up on someone that's injured and you want to help care for them because you have a little bit of training and know what to do. You're protected. You're protected. There's something called the Good Samaritan Law, and I'm going to tell you what it basically is defined as. It protects people who render aid without expectation of payment and within the level of their training. That they make reasonable decisions in good faith for a victim in imminent danger when the victim does not object to help. So, that is where we talk about informed consent and implied consent. If someone is awake and alert and they are aware of what you're doing and they know who they are and where they are and what day it is or who the president is, those are all the questions that we ask. If they're awake and alert and they know all this stuff, they have the ability to decide what they want done or if they want care. That's their choice. But if they're unresponsive, they're unconscious, or they're confused, then that's called implied consent. The other one is called informed consent. This one is called implied consent, and it's what a reasonable person would do were they awake and able to consent to the care. So you're protected from being sued if you, let me just say this, okay? If you do a pryke on someone, cut open their airway, that's not your level of care. And yes, you can be sued for that. But if you help someone by stopping bleeding or splinting a leg or something like that, that's within the level of your care, and you won't be sued for that. So let's see if this works here.
Point it below the screen.
Yeah, I'm trying to point it at the computer there.
Did that work?
Nope.
Is it on? Or is this switch?
Yeah, I turned it on.
Okay.
It just
Back to
doesn't.
the manual control again.
Okay. It's a good thing there aren't a whole lot of slides. Okay, that's a picture of us, Michael and I, when we were teaching first aid. Next one. Okay, we're going to talk about wound care. The first thing is that we want you to make sure that you clean every wound thoroughly, especially when we have a lack of medical care. Cleanliness is so important. If they're not able to get the antibiotics they need, if they're not able to have the ointments and things that they need to keep that wound clean, they get infections, they can lose a limb or die, literally. So it's really important that we keep wounds clean, and that means irrigate, irrigate, irrigate. Water, 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 water. Just pour the water on. Keep pouring it on until you just can't pour any more on. Just make sure that you get that wound cleaned out. If the wound gates open, so if a wound is over a joint or it's naturally gaping open, my daughter cut her hand 2 days ago here on a can lid, and she called me up and FaceTimed me to show me the cut and said, what should I do? And I told her to glue it. So I said, clean it out really good and then glue it. So she takes super glue and glued it together. She did a really good job. I was impressed. And so that'll help that wound heal. You can use steri strips. Steri strips, you can make your own steri strips so easy. You take a piece of adhesive tape and you, in the middle of it, you twist it twice. You pull, put one end here on the cut, you pull it across and pull some tension on it, and you put the other end over here, and you've made your own steri strip. You can buy your own, you can buy steri strips in the pharmacies everywhere. So steri strips, and if those are not working and it's a very large laceration, you may need sutures. So you can either buy your own suture kits, or you can take them to the hospitals if they're operating. So we're going to show you, we want you to understand the difference between a venous bleed, something coming from the vein, and an arterial bleed. So I'm going to show you a video. Now I'm going to tell you, if you're squeamish, don't look at the videos or the pictures that I show. I'll try and warn you before, because there are some actual injuries. This one is a pig leg, so it's not that bad for a lot of people.
Bad for the pig.
It is bad for the pig, yes. Yes, Michael, it is bad for the pig. So if you'll click on the first one.
So what is it, male chauffeur?
Can y'all see that okay? I wish we could. They can't turn the slides. So you can see well enough to see that blood squirting out is doing it at the time of the pulse. That's an arterial bleed. I think it was implied consent. But you see how much blood is being lost, and if you can see it, it's bright red blood. It's not dark blood like venous blood would be. It's bright red blood. So that's coming out, and in this kind of a wound, because it's at the groin area of this pig, this kind of wound, you might close that because it'll play the next one, I think. Not yet. This kind of wound needs to be packed. So what you do when you pack a wound, wound packing is not a gentle, easy thing. It is pretty rough. Some of the things that you can use to pack a wound, there's some specially made materials that you can buy to pack a wound, but just gauze is one of the things that you can use. And you take that gauze and you stick it into that wound as deep as you can get it. So either as deep as that wound is or as deep as your finger will go. You push it into that wound and you're going to keep pushing. Guys, this is going to hurt. It's painful. But I think dying is a little more painful, so we don't want them to bleed to death. No, you don't think so? Oh, well, yeah. Well, good for you, and you're here. So, but you shove it in there really hard and deep, and then whatever is left of your gauze, you wrap it around and make a tight bandage on there. And pad it, put bandage on top, and then use it to wrap. That will hopefully stop some of the bleeding. But we will also watch a really interesting video, and I want to preface this by telling you about this video. This is so good. It is a industrial workplace, and the man is first aid trained, and he comes in and just does an excellent job. Now I want you to notice, number one, how calm he is. When you are calm and you're going in to take control of a scene, You're going in to take control of what's going on with the patient. If you remain calm, they'll calm down. The bystanders will calm down. Your partner will calm down if you have one. If you go in there and you get hyped up and act like it's a big deal and are, freaking out, everybody else is going to freak out too. So I want you to notice how calm he is. The other thing I want you to notice is his hands. When he is doing a primary assessment on this patient, he's running his hands down her. And then he's looking at his gloves, and you'll notice that. He changes his gloves first thing to have fresh gloves on, but he's wiping down her body and looking at his hands. He's putting his hands on her chest to make sure that her chest expands equally. He's pushing on her abdomen to make sure there's not an injury there. What happens is as she gets this injury that she's got, it's called a distracting injury. And a lot of times people who have a major injury will have other injuries that maybe aren't as obvious, and they don't even realize. And so you say, are you hurt anywhere else? And they're going, nope. And they've got a broken leg. So these are things that you need to be looking for, and that's why we do a primary assessment, and you're going to see him do this, and I want you to just notice those things. Can you go ahead with that one? Get out of the way.
My name is Riley, training first aid. Can I help you? What happened?
You slept.
Okay, I need you to hold pressure as hard as you can. Is anyone else hurt? Keep holding pressure. Activate emergency response protocols for a conscious adult female that is bleeding profusely from the leg. On 911 now. Keep holding pressure, you're doing good. Hands off.
Do you see the arterial bleed?
I need your help. I need you to count and grab gloves out of the first aid kit and put them on. Good. I need you to help her lay down on her head.
So this is treating her for shock.
Come to the other side of me and take over pressure. Hand over again as hard as you can. And the second one on top here. Hands back on. Good. What's your name? Good. 911's been called. Help is on the way.
It's a cat.
Looks like you've been bandaged now. Slide this under. Hands off.
Okay. So I want you to notice some other things that were really good about what he did. He was very clear and concise in his instructions, very calm. He also, if you'll notice, he reinforced that bandage twice. So he put the initial bandage on, and then 2 times he added more bandages to it. So that's something we don't see a lot of now. We see people that just think the tourniquet's going to take care of it. He reinforced that bandage twice, and he also put a pressure dressing over it, and that's important. But calm, clear, and concise instructions was really good for everybody involved. He also put the time of the tourniquet application on the tourniquet itself. Tourniquets are great for an arterial bleed, but they should not be just used without caution. When you put a tourniquet on, it causes, you're cutting off the circulation to that limb, and it causes a buildup of lactic acid. The cells, when they don't get the oxygen supply that they need, they have anaerobic metabolism. This produces lactic acid, and that can build up over time. And if someone is elderly or someone has medical problems, that hit of lactic acid can cause some problems in their heart. So that's something that you need to be aware of. Don't just throw a tourniquet on every cut you see. It is no longer life over limb. It used to be that we said tourniquets could be on no more than 2 hours. Now they can be on 6 hours. We're also using a wider tourniquet that is not causing as much tissue damage. So it's no longer 2 hours, it's now longer, but it's still important to put the time that you apply that tourniquet on the tourniquet. And I had a tourniquet out here.
Question.
Yes, here it is.
How much time did you time the windlass until especially in arterial bleeding?
Yeah, we're fixing to talk
You've
about
already
that.
got a bandage on it. How do you tell for certain that the arterial bleeding is stopped and you can't see it?
Well, that's a good question. And you don't really want to peek, but if you don't see it seeping out under the bandage. And if it's an arterial bleed, it's going to. But then what you're also going to do is you're going to be checking for a pulse. Now I'm going to give you all a little tip on pulses. I teach at OTC, and I teach my EMT students this, and they're just amazed at how much better it is. So, you think, come here, Michael. He's going to get the tourniquet too. So, when you get somebody and you're going to take their pulse, a lot of times you're like this, and you're feeling for a pulse like this. It's kind of hard to feel. On him it's not, because he's got a bounding pulse, but what happened, Mike? Okay, can you hear it? Okay. So, here's the deal. You take your middle finger. Your middle finger has more nerves than any other finger. It's the best finger to feel things with. You take it, and you have this little bone on your wrist. You put your finger on that bone, and then you slide it in, and there's a little ditch there that's between the bone and these tendons.
Your battery's dying.
Oh, is it? Okay. How's that? Yeah, okay.
Can't hear her, I can hear you.
So, If you take their arm and you put it like a limp wrist, and then you take your finger, that middle finger, and you put it on that bone, and you move it, we call it medially, but towards the inside of their arm, you feel that little ditch there? There's that pulse. So try it yourself and you'll see. It's a lot easier to feel that pulse because this position moves that tendon out of the way, and it makes it easier to feel, right? So for your foot, I'm not taking my shoes off and I'm not making him do it either.
We all appreciate
So for the foot, you have a pulse in your foot, and it's important to know where that pulse is. So you take the second toe, not the big toe, the one next to it, and you run your finger up that toe. And on the top of the foot is kind of an arch there. Put your finger right there, your middle finger, right along, run along the toe to that arch. Right there you'll feel the pulse in the foot. And it's important to know both of those, because we're going to be talking about pulse motor sensory. And pulse motor sensory is a very important tool for you. It's when someone has an injury, you need to know, is there a nerve damaged? Is there artery damaged? And what you would do is you would take them, like their hand. Just because someone can move their fingers doesn't mean their hand's not broken, because it's the muscles that move, not the bones. So if they can move their hand, doesn't mean it's not broken. The only way to know if something is broken, the only way, is an x-ray. We don't have x-ray vision. So anything that you suspect may be broken is broken until it's proven otherwise, okay? Everybody remember that. If you suspect it's broken until proven otherwise. So, what do? I'm going to check his pulse. Does he have a pulse? He's got an injury to his upper arm here. I'm going to check his pulse. Does he have a pulse? I ask him, which finger am I touching? I'm going to do it without him seeing. Which finger am I touching? Yeah, it was wrong. And you're going to ask him to move his fingers. It doesn't have to move a lot, just a little bit. We don't care. We just want to see that there's movement there. So, he's got a laceration on his arm right here. Big cut, and it is bleeding profusely. You see spurts of bright red blood. Well, what does that tell you? He caught an artery. So we're going to put a tourniquet on him.
Question.
Yes?
You have a pulse oximeter. Is it accurate enough to determine if there is or is not a pulse?
No. No.
Great question.
That is a really great question. I've not ever heard that one before.
That's a pulse oximeter, folks. Put it at the end of the finger.
We'll talk about
A
it.
little battery. Oh, we'll talk about it.
Yeah. Don't get ahead of me. Take your pen out of your pocket. Thank you. So you apply the tourniquet. It's real simple. And you're going to snug it down. Yeah, we're not going to do this lightly. It's got to snug down real hard. And now that it's snug down really hard, I don't want to breathe in this mic. I hate that sound. Okay, so now we're going to take this windlass, this little stick here, and we're going to start turning it. And as I turn it, I'm going to come back and I'm going to check for his pulse. I've only done it once or twice. So in that video, he only did it twice. It's going to take more than that. But he did it on a patient he probably didn't want to hurt. Because this hurts. Okay, we are pulseless. Okay, there. Now I lock it in this little clip here, and then I put this across here, and I'm going to mark the time I put on there. I don't feel a pulse, and in a moment his hand will turn purple.
Pass out on the floor. Then you talk about something else.
So if you have a wound that has been bleeding, And, yeah. And you put the tourniquet on, and it has not stopped the bleeding. And believe me, there are some people that have that. One tourniquet is not enough. Put another one on.
Ever it takes.
Yeah.
They're not on top of each other.
No, right next to each other. So I'm going to show you something else. This is another tourniquet type. There are some people that like these and some people really don't. But it's called a SWAT T. And it's basically a big rubber band. So this is what it looks like. And it's just a big rubber band. So you take this and you take the end of it and put it here. And then you're going to stretch. There are pictures here. So you're going to start it, and then you're going to start stretching. I'm going to.
Just wait. Loves her.
And you always do this above the wound.
Above the wound, as high as you can get it.
This particular thing tends to be really good if you've got to get even higher in the axilla here or in the upper femoral area. This will work, the cat tourniquet will not. It's also way more comfortable.
And so what you do is, you see these pictures here, it tells you when you see the squares turn to diamonds, it's stretched enough. So does he have a pulse? No, he does not, no.
It hurt it.
So, because this is wider, it doesn't hurt as much. It is more difficult to apply. It's very difficult to apply if you're by yourself. You can easily put a cat tourniquet on yourself, but you can't apply this to yourself very well at all. So there are drawbacks about it, and there are good things about it.
How do you turn it off?
You tuck it in. You just tuck it in.
So exercise bands that I have on?
Oh, those work.
Yeah, work,
The
yeah.
physical therapy for your shoulders or elbows,
Yeah.
same thing. But we had
That's-
those first before we ever had these.
Yeah, they work really well.
You can also use
So-
tank pump if you wish.
Yes,
Those also work a lot better on children than cats.
That's correct, sir.
yes, they do.
And you can actually put this directly over a wound, because just like the video that you showed, where somebody had like a stretching thing, anything for bleeding, the one word is pressure. That doesn't matter how you get it or what you put on it. If you have a blood pressure cuff, you can literally stick that over a wound that's bleeding. Pump it up till the bleed stops.
Could you put it up higher and pump it
No,
out?
sir, well, you can, and then it'll work like a tourniquet, right?
Yes,
Then
but the
it'll
problem
slowly-
with that is it'll slowly leak out.
Slowly start going.
Okay.
Yeah,
Doesn't hurt.
I'm done for now, maybe later. Did you see what he did to my soda? He shook it up before he gave it to me. Do you have a question?
You talk about expedient terms. Expedient.
Expedient? You mean like,
If you're up in the mountains and.
Okay. yeah, you can take a piece of cloth, you can take a belt. These things you can make tourniquets with. If you take a piece of cloth, you use a stick as a windlass, and you can twist it. There's a lot of different ways that you can do that.
Those good, these are good times.
Yes.
This is something that's good for the kid, they're triangular bandages, and like she said, you can tie those with sticking wood or something. That's good.
Yeah, you can, this is a triangular bandage, and it's used, I'll show you in a few minutes about a sling and swath, splinting. So, when you pack the wound, you don't pack wounds in the chest or the abdomen. You pack them in the axilla, or the groin, or the neck, but you don't do it in the chest or the abdomen. Penetrating trauma, you get gunshot wounds, knife wounds, that happens a lot. Impaled objects. So you can get an impaled object. Guy I knew when I was a girl, I'm still a girl, but I'm a little girl. When I was a little girl, there was a guy I knew that he was in a tornado in Springdale, Arkansas, and a branch from a tree went through his chest. Totally went through his chest in the wind. Also, one went through a tree too, but it was a different branch. There's all kinds of things. There was, all kinds of incidents, people falling on sharp objects or falling on something that's maybe not so sharp, but it's rigid, and you fall with enough force. Impaled objects, so something that goes in and is still there. The number one rule of that is don't ever remove it unless it is impeding their airway. The reason is this has to be removed by a surgeon because it's likely that there are blood vessels, that this may be tamponading the blood. It may be stopping that blood, and you pull it out. Many, many years ago, when I worked in the emergency room in Tulsa, we had a case where a woman was shot with a crossbow. She was shot in the chest with a crossbow, and she pulled it out. Had she not pulled it out, she might have survived, but she did not. So removing a impaled object is, unless it's blocking their airway some way, leave it alone, get them to the hospital where it can be removed under surgical care. I really don't know, but I was taking care of her. I took her to surgery. So you have a wound in the chest. You can have what's called a sucking chest wound. So gunshot wound, penetrating trauma of some sort, stabbing, arrow, whatever. You have a wound in the chest, and we call it a sucking chest wound. And that's because as the patient breathes in and out, so does air go in and out. And it can cause a buildup of air that will cause a tension pneumothorax, which will put tension on the heart and the lungs and the great vessels in the chest and can cause death. It's very, very critical that be taken care of. So one of the things that you can do for that is you can apply a chest seal. Now there are several types of chest seals. Everybody has a high-fin chest seal. I have one. They're handy to have, but there are other things that you can use as a chest seal. You can use a piece of saran wrap. Saran wrap will be fine. You can use Vaseline gauze, which is a bandage that is like a 4x4, but it's covered in Vaseline. Anything that's going to let air out but not let air in. You can do a 3-way bandage there, and you take 3 sides of the bandage, but it needs to be an inclusive bandage and not one that'll breathe through. So I have a video here on how to do a chest seal.
Hi, I'm Anthony and I'm a paramedic, and today I'm going to demonstrate to you how to treat a sucking chest wound using a chest seal. The first thing we need to do is remove the clothing to expose the injury.
Yeah, I know, ladies, this is for you.
When the injury is exposed, remove the chest seal from its packaging, and you can also examine the patient and check if there is an exit wound. When the chest seal is removed, clean the area of any blood or fluid. Remove the protective film from the chest seam. Place chest seam directly over the hole. Ensure that the chest seam is in place. When the chest seam is in place, we may then inspect behind the patient, looking for any exit wounds of the body. Inspect your gloves where you cannot see.
He rolled up for you. Yeah.
All right, so that's a chest seal, and you notice that he was looking at his gloves to make sure as he's looking for a second wound. Sometimes there are entrance wounds and exit wounds, and sometimes there are just entrance wounds. Yes.
When I was in the military, they would teach you how to treat, a sucking chest wound. And basically, they would just use the plastic off of the package that the bandage was coming, and that was good enough. Is that good enough?
Yep.
Okay.
Yep. Tape it down on 3 sides, not on 4. Yep. I would say that would be a good one. There's a lot of things that you can use. Yes.
Avoid black gloves because it's hard to see blood on it, especially if it's dark.
Yeah, that's exactly right. Black gloves. Pardon me?
Why?
Because you can't see blood on black gloves. It's very difficult to see. And the same thing with blue jeans. When you've got someone that's got blue jeans on or dark colored clothing, it's hard to see the blood. So, I don't know how much blood he's gotten on those britches, but you'd never know. They've been washed, guys. Abdominal wounds. When you have an abdominal wound that is penetrating, sometimes you can have what's called an evisceration, and that's because the abdominal contents are under greater pressure than the outside air, so you can have some intestines come out the hole. That's called an evisceration. It can be just a little bit or it can be a lot, and it depends on the size of the hole and the amount of pressure on it. The first time, I'll never forget the first time I saw an evisceration was a fellow walked in the emergency room where I was working, and he said, "I've been shot." And he takes his hand away and there's about that much bowel hanging out. And he had been working at the Mazzio's Pizza, and some guy came along to rob him and shot him. So he did fine. He had a long recovery because intestines have a lot of bacteria in them, and that went into his abdominal cavity, and they had to do a lot of cleaning out of his abdominal cavity and then long-term antibiotics. So now we're going to talk about burns. Yeah.
What do we do with an evisceration?
Thank you. An evisceration, you want to use a moist dressing to cover it because you don't want that intestine to dry out. So if someone has got a wound like that, you're not going to push it back in because it needs to be cleaned. That whole abdomen needs to be opened up and cleaned out. Any bleeding stopped. So you don't push it back in. You cover it with a moist dressing. So a gauze with saline soap or water soap even. Just put it on there and keep that intestine. Thank you very much for that. So now we're going to go to burns. So in the picture are some pictures of burns, and we have actually 5 degrees of burns. The 1st degree burn is what you would get if you got a sunburn that's a little bit bad, This probably was some boiling water that got on the hand. So it's just a 1st degree burn. It gets red. It hurts. It's very painful. This top picture here, that's a 2nd degree burn. And sometimes you get a sunburn that's a 2nd degree burn because you blister. Blisters mean it's a 2nd degree burn. The bottom picture over here is a 3rd degree burn, and you notice it's white with charred edges. It is this center area here that's charred has no pain. That's not painful because the nerves have been burned. The area that's around here, that's red, is probably pretty painful. Any burn that you get that's to the hands, the face, the head, or the hands, the face, the genitalia, or the airway are critical burns. Any burn that is above 10% in a child, 10% of their body surface area is burned, or more, that's a critical burn. In an adult, for 15 to 20% of their body, anything that is 15 to 20% burn, anyone adult, that is a critical burn. The most important thing with a burn that involves the face is look in their mouth and their nose for soot. A lot of times when people get a flash burn, an explosion, they will just instinctively inhale and hold their breath. Well, when they inhale, they're pulling in a lot of superheated air, and that whole airway gets heated and burned. And what happens then? It swells. Very quickly it swells. And it's important that they get medical care where they can put a tube down and keep that airway open. If they don't, they can die. The biggest concerns are, first I want to tell you though, the types of burns that you can get are chemical burns, thermal burns. Chemical burns like lye, things like that get on the skin, will burn your skin. Thermal burns, different sources, falling in a fire, that type of thing. Friction burns, so someone gets road rash because they had a wreck on a motorcycle and they didn't have long pants on. We see a lot of that. Radiation burns, a lot of people who have radiation treatments at the hospital will have burns on their foreheads from the radiation treatments, or other places. And electrical burns. Electrical burns, if you see an entrance wound for an electrical burn, you need to be looking for an exit because that burn will travel through the body and come out somewhere else, and usually the feet. You need to make sure you keep the burned area clean. So wash it with water. Wash it with water if you're not able to get medical care. But it's also important to keep the person warm. Warm people, your skin is what's keeping you warm. It's protecting your body. And if that skin is gone, you lose a lot of body heat. You lose a lot of body fluid too. And so there's formulas that we use in medical care of how to replace that fluid and how to replace it over a certain amount of time. So we use those formulas to figure out the fluid replacements with an IV. But if you don't have medical care, then you've got to keep them warm and you want to rehydrate them if possible. Head trauma. So you have someone that gets hit in the head. They fall, something swings and hits them in the head, somebody's playing softball or something, gets hit with a bat, they get knocked out. This is concerning. If they get knocked out, if they have a loss of consciousness, they automatically have a concussion of some sort. You don't have to be knocked out to have the concussion, but if you are knocked out, you've got at least a concussion. And that is because your brain has been bruised. That's what a concussion is. It's basically a bruise of the brain tissue. You have what's called a coup contra coup effect. So you have where your brain basically is inside this skull and you get it hit and it bounces off the other side. That's the coup contra coup. So you get an injury over here, but you also get one over here. Head injuries, it's if you're not able to get them to medical care for some reason or another, it's extremely important that they rest, that they not be having to do anything physically active, that they rest their eyes especially, no screens, no reading, and this may need to be done for weeks until they're better. So if it's possible to get them to medical care, they need a CT scan, they need to see where the damage is and how extensive it is. Head injuries can fool you. You can have someone that has a fall and hits their head, they are unconscious, then they wake up, and then a few minutes later or hour later, they're unconscious again because they're having a bleed in their brain. Elderly people or alcoholics, people who have a lot of consumption of alcohol, they get brain bleeds frequently. And elderly people, when they fall, because as we age, I count myself in this, our brains shrink. So there's more room in there for your head to, or your brain to bounce. So it's important, a lot of times people who have head injuries will be vomiting. They'll be vomiting profusely. This is a sign that they need to get medical care, especially if they have what's called projectile vomiting. And projectile vomiting is where they do like in The Exorcist, and they vomit across the room. It's very dramatic. These are signs that you need to take them to the emergency room, if possible, get them medical care. Their eyes, you check the pupils of their eyes. Guys, know if you have unequal pupils. There are some people that have normally unequal sized pupils. Medications can cause unequal sized pupils, but a head injury can cause unequal sized pupils. And if I come to you and I say, are your pupils normally equal? And you tell me yes, but they're not equal now, then I know that this is reason to believe this is a head injury that's pretty severe. So these are things that you need to be thinking about when you have someone that's been hit in the head. Vomiting, nausea, is something that happens a lot of times during all kinds of things happening. You can break a leg and get nauseated and start vomiting. You can fall down, or my daughter one time passed out and was vomiting because we had her sister, who was little, in the doctor's office, and the doctor was looking in her ear, and my daughter, the younger one, said, ouch, and the older one passed out and started vomiting. I caught her head as she was falling. And apparently I threw the other daughter to the doctor. I don't remember that part, but she seems to. So something that you may not know about, but I'm going to tell you a little tip about, is alcohol, rubbing alcohol, can stop nausea. So it doesn't in everybody, but it does in a lot of people. And when I worked in the emergency department in Lebanon, I would very frequently just open some alcohol packs and stick them under someone's nose that was sick, that was nauseated. And what that does is that alcohol scent wipes out the nausea center and kind of resets it. Well, that's what I would do all the time. And by the time I left there, all the nurses were doing it too, because it works. Just to smell it, don't drink it, just hold it under the nose. And I would give them alcohol packets, the alcohol white packets, and I would say, if you get nauseated again, open this up and sniff it. And they would. It does help. Another little tip for you. So we're going to talk about shock, and there's several causes of shock, but shock is, by definition, the sudden loss of blood flow through the body. Okay, it's not, I saw something terrible and now I'm in shock. That is not really shock. That is something else. Emotional shock. But it's not real physiological shock. Shock is the sudden loss of blood flow through the body. A lot of things can cause shock. You can have trauma, heat stroke, heart problems. You probably had pretty severe shock. Blood loss. So you can have blood loss from a lot of different things. A GI bleed, so somewhere in your stomach or intestines. Esophageal bleeds, a lot of things. Any type of bleeding internally can cause it. Severe infection, or sepsis it's called. Spinal injuries can cause shock. And dehydration can sometimes get severe enough to cause shock too. So, shock, the treatment that you saw up there of this young man when he was taking care of this woman, he's treating her for shock. So what he did was he had her lay down. Sometimes you can elevate their legs, but in this case it wasn't really a good idea because she had that big, huge laceration. The other thing is to keep them warm. Give them some warmth. People in shock that haven't got enough blood flow, they get cold very easily. I can attest to that. Well, heat stroke doesn't usually cause shock, it causes a stroke. So we're going to talk about stroke. We're going to talk about hyperthermia. Can't remember the next slide. Can't remember if it's, okay, that's it, that's okay. We'll show that, we'll talk about that in a second. We're going to talk about hyperthermia, which is overheating. So a lot of people say, I had a heat stroke. And they're perfectly fine walking around. That's not a heat stroke. They had heat exhaustion. A heat stroke is a true stroke. It's damage to the brain. And that damage to the brain is usually permanent. You don't really regain brain tissue.
50% of heat strokes die.
Yeah, that is true. 50% of heat strokes die. It is a big emergency, and it is, like I said, it is a big emergency versus stroke. Heat exhaustion is another animal. Heat exhaustion can cause severe heat cramps because they've lost their electrolytes. It can cause profuse sweating, redness. When you have a heat stroke, they've lost the ability to sweat. So you're not going to see sweating. They'll a lot of times have nausea and vomiting, and that makes rehydration difficult. You need to get them out of the environment, get them into a cool area if possible, douse them with water. Water's great. Water will cool them off. Get them in the shade somewhere out of the sun. You know what's interesting is I used to work in Las Vegas on the ambulance there. And we had very, very few people with heat exhaustion. You know why?
When he stays inside.
No, that's not it. Yeah, I can understand that, but no, it's because your sweat does what it's supposed to do. It evaporates and it cools you off. That's what sweat's supposed to do. And the humidity here, we don't do that. It just drips on us, and it soaks us, and it doesn't really evaporate and cool us. So we get more heat emergencies here than they do in the desert. Due to dehydration, you're dehydrated when you're hypothermic, or hyperthermic rather. When you get too hot, you get dehydrated, you sweat all this sweat out. It's important to rehydrate them, and sometimes it's hard to do that because it causes nausea and vomiting. Hyperthermia, or hypothermia rather, is also a very serious emergency. There's a saying that we have in EMS, they're not dead till they're warm and dead. Because once you get their body warm enough again, they may end up having a pulse back. With someone who's severely hypothermic, where their temperature is down into the danger range, they're past the point of shivering. They're not shivering anymore. Shivering is a way to preserve heat. It's not working. So they're past the point of shivering. They're losing their ability to think. They lose their motor skills first, and then they lose their ability to think. It just progressively gets worse, and unless they're warmed up, they can die. So some of the things that you can do, remove their clothing. Get the wet clothes off. Usually, if they're wet, that's part of the issue, is get the wet clothes off. They're better naked and dry than they are clothed and wet. So get their clothes off. warm them up. So how can you warm someone up? What are some of the things that you can do to warm someone up? That's it, body heat. One of the best things that you can do, if you've got a sleeping bag, if you're out in the wilderness somewhere or out somewhere by yourself, or with the two of you or by yourself, get in a sleeping bag together. Use that body heat. That's one of the things that you can do. What's another thing that you can do? Friction, not if there's any frostbite, but that's not going to warm them internally enough. Warm to drink, if they're able to, yeah. Build a fire, and what do you build the fire and do? No, don't throw them on it. Okay, you find the biggest rocks you can, and you put them right beside that fire. You get those rocks not hot, but you get them warm, and you want to put them in the groin and the armpits. Why? Because you have major blood vessels in your groin and your armpits that is pumping blood through your body, and if you help warm that blood up, it'll take it all over the body. So groin and armpits are where you want to put the heat. What are some other things that you can use for heat? Hand warmers. I got some for Christmas. I have a saying, my Indian name is Old Woman Who's Always Cold. I'm cold all the time. In the summer even. I go in air-conditioned places and I freeze. So, hand warmers are great. I was using mine today. You can also take a pillowcase and fill it with corn or fill it with rice and heat that. Just stick it in the oven and heat it if you're at home, or stick it by the fire and warm it up there. Try not to burn it. Don't use plastic, please. It will melt. But then use that, and again, warmth in the armpits and the groin. So, frostbite. We'll talk about frostbite here. This is a picture of some frostbite. You'll notice, I don't know if you can see it well enough or not, but she's got blisters on her fingers. And frostbite is kind of like a burn. It kind of has the same damage. What happens is in the capillaries, those cells in the blood get frozen, and then they're like sharp, and they cause damage. Tissue in the cells, the fingertips of the hands, that tissue gets frozen, and it's like ice shards in there. That's why you don't rub it, because you'll do more damage by rubbing a frostbitten extremity than you will by warming it up. So this is an early frostbite. If you'll show the next one. Okay, this is a 2-day, this is the second day after frostbite occurred. Do you think he's going to lose those toes? Oh yeah, absolutely he will. These are the fingertips, and frostbite is usually recognized by a white, waxy appearance on the skin. I had it on my cheeks one time when I was a kid. Had frostbite on my cheeks. I lived in Nebraska. They had the worst winter in 40 years, and I was out building a snowman or snow woman. Got frostbite. So what do you do about this? You gently warm it up. You don't rub it. Yes?
Only warm it if you know you can keep it warm. You don't want to do
Yes.
it to refreeze.
You don't want it to refreeze, and the longer the exposure, the worse it'll be. So if you can warm it up and know that it's not going to be refrozen, do that. Warm something when you know you're going to be able to keep it warm.
You said bright and white, waxy?
It's white, and it's not bright white, it's white and waxy. Okay, we're going to talk about fractures here. Michael, come here. How are we on time?
It's about 7:15.
Okay, yeah. I saw you. I'm aware.
Sorry, we can break.
Okay. This is a SAM splint, but this is a military SAM splint. Need that. So when you splint an extremity, any extremity, and there's some pictures of splints, what you need to make sure that you do is, this is a sling and swath, this is for a shoulder. So you have a shoulder injury, you can't really put a splint on that real well, so you want to immobilize it. You want to keep it from moving. So what you would do is you would put that either, you can put it in a sling like this, or you can strap it like this. I personally prefer this because it keeps it more immobile. But you can take an ace bandage. Here's an ace bandage. Would you open that for me? I'm gonna need it. You take that ace bandage and you just wrap it just like this. And then you wrap around the body. That's the swath. So you have the sling and then you have the swath. I don't need it right this second. But this is an ace bandage. It's elastic. So you immobilize that shoulder and you keep it from moving. And so you can use the triangular bandage to do that too. And you can make a sling with the bandage. A lot of people have a lot of trouble with this because they forget which way to put it on. And I'm going to show you the way to put it on. You have a triangle. That's your triangular bandage. So you take that triangle and you tie a knot at the bottom of the triangle. Just tie a knot right there. And then you're going to put that knot on the elbow. So the elbow is where the knot is. And then I'm going to take, I can do it. Thank you. Then I'm going to take my ends, rest your arm in it. Thank you. Except pain in me. You're going to take the ends and you're just going to come up and you're going to tie them around his neck. Now, you don't want to tie the knot directly on the back of the neck. You want to go over to the side because that, especially if they sit back on something, that knot will be right there and that's not very comfortable. And you just tie the knot. And you ask them as you're tying it, let me stand up here. You're too tall. Okay, stand up now. Okay, so you tie this on and you ask them, does it feel like it's supporting your arm? Is it?
Oh, sure.
I'll tighten it more then. Okay, so then, I don't need those. Put them in your pocket if you want them. So then you take your ace bandage, or you take another triangular bandage, or anything that you've got, and you use a roll of Curl-X, and you wrap around under the good arm. And that will keep his shoulder from moving. And that's called a sling and swath. Okay? Now, I'm going to show you something else about when you roll something on. So you've got a bandage that you're going to roll on. Let me use one that's already rolled so I don't have to stand here and do that. Here's a little trick about this. This is Coban. People call it vet wrap. It's the same thing. Vet wrap comes in really cool colors though. So you have Coban. If I roll this on like this with okay, think about a toilet paper roll. Which is the right way? Over the top. Well, if you roll a bandage on, you're going to do it the wrong way. You're going to do it under the bottom. So you roll it like this, on the bottom like that. Then, it's a lot easier to do than if I were to do it like this, where I'm having to switch it around. And it's awkward that way. So, if you roll it the wrong way for the toilet paper roll, it's a lot easier to do. Okay, so now we're going to talk about the splint. If you'll go to the next slide. Okay, this is a leg splint, and I want you to notice something about this. On this leg splint, of course, they're needing to wrap that so it'll stay on there, the leg splint. They're just showing you the position that her foot is. Her foot is not completely flexed back. It's kind of in a relaxed position. If you're laying on the ground, your foot is not going to be flopped over like that. It's not going to be straight up. It's going to be kind of halfway. That's called the position of function. Now, I would be really happy if they had a roll or something underneath her knee, so she's got a little bend in her knee to support it there. That would be good. But that's position of function. Here you see a SAM splint being used, and here they use tape to wrap it and hold it on. You can use tape just fine. You can use Coban, you can use Curlex, you can use Ace bandages, whatever you have to hold that splint on. But you'll notice again, his foot is in the position of function. Position of function is important because if you splint something, and especially if it's there for a long time, in the wrong position, you can cause more damage. So, come here. 37 years. So we have here, this is a SAM splint, and it's basically a foam with metal inside, very lightweight metal, I think it's aluminum. And it is flexible, and you can form it to anything. They've got it here in this picture on an ankle, if you'll show the next slide. Here they've got it on the arm, on the forearm. And I want you to notice this forearm. That forearm, the hand is slightly cocked back, and it looks like they're holding a can of Coke. That's how you want them splinted. If you're sitting relaxed, not moving at all, your hand is kind of like that. Just completely relaxed. You're holding a can of Coke. That's the position of function. So when you make a splint, you want to make it in the same shape as their arm. So what am I going to do? I'm going to use the arm that's not injured to form my splint. So I'm going to go like this, and I'm going to curl, place for his hand to rest, and then I'm going to come along here, and I'm going to shape to his arm. And it's easy to shape these splints, but I don't want to do this on the injured arm, because it would really hurt. So I put this splint on like this, and then I'm going to use something to hold it on. I've got some Coban here. Now before I start wrapping this on his arm, and this would be for the other arm, I'm going to say, can you feel me touch you? Which finger am I touching? Can you wiggle your fingers? And does he have a pulse? So I'm going to feel for a pulse. There's another thing that you can do if you can't reach the pulse for some reason, and it's called capillary refill. And so you pinch on the nail bed here. Until it, just for a second or two. And then you say, then you release it and you look to see when the color returns. If the color returns before you can say capillary refill, or before you can count 1, 2, 3, it's fine. It's good. I worked with when I taught in Las Vegas at the paramedic program there. The instructor said by the time Carol says capillary refill, a dead man would have a normal response, because she thought I talked so slow. She was yang. So, okay, so you press on the fingernail bed and you look and see when the color returns, and it returned before I can say capillary refill or count to 3, so it's good. So then I would put the splint on. I'm going to do it on this arm. So I put the splint on, and then I'm going to wrap it. these things get put in a box for a while and they get molded together and don't work real well. So, his arm is injured. I'm gonna start wrapping from the distal end. So the furthest away from his head, that's what I wanna start the wrapping at. And I wanna make sure that I don't get it too tight. So I'm gonna pull out
Normally do this before the sling.
before the sling, yes. Yes, I would. I was just demonstrating sling and swath, so it's on him there. So pull it out. You don't want it too tight. You want it just to hold that splint on. We're not putting pressure on a wound. We're just holding that splint in place. And you wrap it. It's important that when you splint an extremity, you splint the joint above and below the injury. So if he's got an injury here, I want to splint it from his wrist to his elbow. Where's it going? Here it is. And what's nice about Coban is it stays there. And after I have splinted this, I'm going to again check for pulse, motor, and sensory. Now, I can't reach his pulse, so I'm going to do the capillary refill. And I'm going to say, can you feel me touch you? Which finger am I touching? I was. Can you move your fingers? Good. Okay, so that's good, and you always want to do that. And then you would put the sling on. You don't need to put the swath on if it's a lower arm. What are some things that you can think of to use for splints? Newspaper magazine, great. Roll the newspaper up to where it's rigid or more rigid. What else? PVC, yeah. You got cardboard. That's a good one. A lot of commercially made splints are made of cardboard. How about sticks? Just some sticks. There's a lot of things that you can use. You can be inventive. One of the best things that I know of for a splint is a pillow. It's soft, it's not rigid, and you can form it how you want. So sometimes you can have what's called an open fracture. An open fracture is where you have bone ends that have come through the skin. And so a lot of times when that happens, you don't see the bone ends sticking out. They've gone back down into the skin. Either somebody has moved it or the patient has moved it or something, and it'll go back in. So when you have an injury that you think is broken, and remember, it's broken until proven otherwise. So if you have an injury that's been broken, that you think there's a fracture, and there is a wound over it, there's an opening in the skin over it, it is an open fracture until it's proven otherwise. Who can do that? A doctor. They'll need to x-ray and see if if it's broken in a way that would cause an open fracture. You have fractures that are non-displaced, and by the way, fracture, when I say fracture is the medical term for broken. I've heard so many times through my career, so many times, people will say, it's okay, it's only fractured, it's not broken. It's broken. It's broken. And so when you have a fracture or a broken bone, sometimes that broken bone is broken. It's called a green stick fracture. It happens more often in kids. It's kind of like a green stick that you break and it's still partially together. That happens with kids. You can have spiral fractures where it goes along the bone. You can have compression fractures where it's pushed against and so hard that that bone is broken there. And you can have comminuted fractures, which are bones that are in a million pieces. There's a lot of different fractures that you can have, and we don't have x-ray vision. So, as I've said before, it's broken until proven otherwise and treated as such, so splint it. Okay, got a video to show you on CPR, and this is hands-only CPR. I hope you never have to use CPR or have it done on you. It is, my daughter had it done a few weeks ago. She had her tonsils out. It's very dangerous for a 35-year-old to have her tonsils out. She had her tonsils out, and then 10 days later, which is abnormally long amount of time for it to happen, she started bleeding, hemorrhaging from the tonsil site, the tonsillectomy site. She went to the ER, and while she was in the emergency department, she coded. She was in cardiac arrest for a minute. They got her to surgery and got the bleeding stopped, but I almost lost my daughter. This can happen very quickly. But we're going to talk about, I want to tell you this, in CPR, the thing that's going to save people is not the IV or the tube down the throat. The thing that's going to save the people is not the drugs that we give, the epinephrine, the lidocaine, the amiodarone, all of these things that we give as paramedics. The thing that's going to save someone is electricity, being shocked. That shock going through the heart. That's what's going to save people. Every single cardiac arrest save that I've had in my career, and I've had quite a few, every single one was when I shocked them. Every one of them. It was not me giving them drugs. It was not me doing really great CPR, although CPR is absolutely vital. It was not me starting an IV. It was not me putting a tube down and intubating them. It was electricity. So this is the most important thing, and that's why an AED is important. And if you're able to purchase one for your household, do it. But I'm going to be showing you a little bit about the AED in a minute. We're going to watch this hands-only CPR.
PODS is your personal moving and storage team for moves across town or across the country.
If you see a teen or adult suddenly collapse, it's important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to send someone to call 911 or call 911 yourself. Then get directly over the victim. Put the heel of one hand in the center of the chest, then put your other hand on top of the first. Then push hard and fast in the center of the chest until help arrives. It's important to push, giving 100 to 120 compressions per minute, which is about the same tempo as the song Staying Alive. Let's hope you never have to use hands-only CPR. But if you see a teen or adult suddenly collapse, don't be afraid to try it. Remember, call 911, then push hard and fast in the center of the chest until help arrives. Your actions can help save a life.
So that's really simple, isn't it? You go and you put your hand in their chest. You put your hand in the chest. You put the heel of your hand in their chest. On men, not on women. Okay. But you put your hand there, the heel of your hand. You take your other hand and you're going to put your other hand here on the back of your hand. Grab your fingers so that you're not putting pressure over here on this side of the chest. You're putting it right. You want that pressure right on the sternum. The sternum is that bone in the center there. And so you put your hands here and you press hard and fast to the tune of Staying Alive. Do it in your head. Women's nipples are not in the same place as men's. Find the bone. Find the bone. Or actually, it's right below the armpits. Right below the armpits, okay? Pretty much, yeah. Yeah, the xiphoid is that point at the end of your sternum, and if you take two fingers and you put them right here, and then put the heel of your hand here, you've got the right spot. So, thank you. We used to teach to do mouth to mouth, and they have learned that the oxygen in the blood stays at a good enough level for about 10 to 12 minutes that it can be, you don't need to ventilate. A lot of the reasons that people didn't start CPR was they didn't want to do mouth to mouth. So the American Heart Association started teaching this. Does it work? Yeah. Yeah, it works. It works.
Is the old style, did it do not better than this actually?
I don't think so. The reason I don't think so is because people would pause their compressions. This is the most important part. Get it.
Expanded number, so you weren't worried about mouth to mouth, you had one person do compression, another.
You can do that, and they'll teach you that in a CPR course, yes. But if you're just out and about and someone collapses and they don't have a pulse, now you'll notice in that video what she did was she called 911 and then she had her phone on speaker and laid it on the ground and was starting CPR. This is important. It is important that the CPR not stop. It is important that it be hard and fast. You press hard on that chest and you do it 100 to 120 beats a minute. That's a normal heart rate for an adult is 60 to 100. Yes, yes, you're squeezing the heart to get the blood flow out. So you want to do it at a hard, fast rate, and you want to continue it and not stop. People used to stop to check for breathing, and they would stop to check a pulse, and they were stopping all the time. They would stop to change people on the chest, and it doesn't work that way. It doesn't help. So we don't want people to stop. So when you have an AED, you take the AED, someone's doing CPR, you come along and you take the AED and you put it on them. These are very well used. This is a trainer. Very well used AED pads. And it shows you on the AED pads where to put them. It's not a big deal. You just put them on there. You slap one over on the right side of the chest, and you slap one over kind of in the area under the armpit. What you want is you want that electricity to go through the heart. That's what you're doing, is you're getting that electricity through the heart. Yeah. So what we're going to do is I'm going to show you. It's going to tell me the steps to take. This thing is just like foolproof. So I turn it on.
Analyzing heart rhythm.
Well, it thinks I've got the pads
Do
on.
not touch the patient.
So it's gonna, you put the pads on, it's gonna tell you analyze the patient. This is when you do not touch the patient. Now, when it says shock advised, I'm gonna be doing this. I'm gonna be pumping. So when it tells me I can press that button, then I'm gonna press the button.
Shock delivered.
Shock delivered, I'm gonna be right back on here.
Begin CPR.
Do you see how long it was? From when the shock was delivered to where it said begin CPR. Some of them take 6 seconds. That's 6 seconds without blood flow. Yes.
Where do we get these? Do we buy these?
I think you can get them on Amazon, as a matter of fact.
How do you tell if the heart is restarted?
Well, that's what I'm going to talk to you about. So it's going to be, you're going to be doing this, and you're going to keep doing CPR, and it's going to tell you after 2 minutes, it's going to tell you don't touch the patient, and it's going to tell you shock advised again, or it's going to tell you no shock advised. If it says no shock advised, then you check the pulse. If it tells you shock advised, they're still in AFib and need to be shocked again. But one of two things, if it says no shock advised, they're going to be in asystole, which is the flat line, or they're going to have a pulse. So that's when you check the pulse, yes.
It's still recommended that you remove all metal?
No, it really doesn't affect. You don't want to, of course, put one of these pads on a necklace, on top of the necklace, because it'll end up burning them. But this is so much better than when we used to do the big monitors that we had the paddles and we had to hold them on there. I did that one time in a car wash. A guy that had collapsed when he was washing his car. Got him back, by the way. He was a save. But, I was like this, shocking him because we didn't know if we'd get shocked or not.
What voltage does it deliver as DC?
It's in joules and, I don't know, I think it's 300 is the initial. I think so. So it will tell you what to do and when to do it. But don't delay getting back on the chest. Make sure that when you are pressing that button to shock them, that nobody's touching them, because they'll get shocked too, including you. Don't touch them. So that's when you stop touching the patient. You say, everybody clear, you look and make sure, and then you push the button. And then right back on that chest and do compressions again.
So literally, if you don't have something to shock and they have a heart attack, compression aren't gonna do anything, you're not gonna lose something about it.
Well, it's very likely that they won't survive that. Yeah.
So if she hits fan, like this is going, that's when the irritate. You should have one.
Pretty much. Yeah.
Except the people, they say CPR only and there's not an AED around. Do they, what's the percentage of their heart will restart on its own?
Oh, very, very small percentage. I mean, less than half of 1% probably. It's a very small percentage. If you don't have the ability to shock or you don't have the ability to get advanced life support care, yeah. So the other thing that I wanted to talk to you about, one more thing and then we're done. Yes. I don't know for sure, but I think they're like 4,000. They used to be. I don't know.
You can put about 1,000.
Can you?
You have to have a prescription in the state of Missouri, but the
Oh.
first doctor will give you a prescription.
Yeah.
for AED.
Yeah, but I really strongly recommend that you take a CPR course. So we have blood pressure. We're going to talk about blood pressure. We have right here, we have a blood pressure machine that's automatic. It does a pretty good job of telling you a true blood pressure. I am not a fan of the wrist ones. I've seen so many of those wrist ones give bad pressures, but this type here that goes around the arm here, it does a good job. Here's a regular blood pressure cuff. This is called a sphygmomanometer. Yes.
They also make those automatic ones with great big numbers, which come in really handy if it's loud and you can't hear anything except for all the noise going on. It gives you something you can see while you're busy doing.
Yeah, this one has big numbers. So, normal blood pressure, you want first of all, you have your systolic, which is the top number of the blood pressure. That's called systolic blood pressure. That is during the heartbeat. And then you have diastolic blood pressure, which is between the heartbeats. And so your top number is your systolic, your bottom number is your diastolic. There should be 40 points between them. 40 points. So if somebody tells you your blood pressure is 120/100, it's not right. There's only one instance where you have a narrow pulse pressure. That's what that's called, is a pulse pressure. And that's with a head injury. A head injury will have narrowing pulse pressure. That's the only case. The other times, if there's not 40 points between, recheck it. And it doesn't have to be exactly 40. You can have 38. You can have, close to it, or you can have 42. But it's important that you know that for yourself. So if you go and they tell you your blood pressure is this, you can say, can you take it again? Some of the worst blood pressure checks I have ever had were in a doctor's office. And they didn't know how to take your pressure accurately. So if you're in doubt, if you have any thought that that's not correct, recheck it. Pulse rate is normal between 60 and 100. What happens if you run? It'll go up. Yeah. So a resting heart rate is normal between 60 and 100. My resting heart rate is generally in the 50s. But some people are that way. Some people have a higher resting heart rate if they have metabolic disease. So they're diabetic or they have hypertension, they have a higher resting heart rate. Respirations, you're breathing, adults breathe 12 to 20 times a minute, that's normal. If someone is breathing 8 times a minute, that's not good. They need to, either they're really, really deeply asleep, usually with drugs on board, or there's something else going on. So if someone's breathing too slow, 8 times a minute, that's too slow. Stimulate them. Usually stimulation, just moving them around, getting them breathing faster. SpO2, so you have something, you have a tool here that you can use that will tell how much oxygen is in your blood. Now this is not an absolute. Please don't rely on this thing. I got treated horrible because my hands were cold. Cold hands will cause this to read wrong. I turned it on. There it is. This will tell my heart rate and it'll tell my oxygen level. What it does is, and it will read if you have CO poisoning, carbon monoxide poisoning, you may have a normal SpO2 or even a high one, because it doesn't tell the difference between carbon monoxide and oxygen. So my oxygen level with me talking this much is 97, and my heart rate is 90 or 87. So with me moving around up here and talking and stuff, yeah, that's probably about right. This is not something that you rely on as an absolute, but it is a good clue for you. Anyone whose oxygen is below 90, and they don't have COPD, which is emphysema, bronchitis, if they don't have those and their oxygen is below 90, they may need some oxygen. But one thing that you have to remember is oxygen is a drug. It is a drug. You have to have a prescription for it. Someone who works on the fire department, they've got some sort of a medical director that has signed off and said that they can carry oxygen. Oxygen, if it's too much, if you get too much oxygen, oh man, back in the day, we used to work cardiac arrest, and we would get those oxygen levels. They'd get in the hospital. We didn't have pulse ox, but we'd get those oxygen levels, and when they do the blood gases in the ER, and they'd come back and they'd say, your oxygen, your PO2 on this patient is 100%, and you're like, yes! It was bad. We were causing a release of free radicals, which is inflammatory. It was a bad thing. We didn't need the oxygen level that high. We didn't know that then. We just thought we were rocking it. We were not. So remember that an oxygen with someone who has COPD, their normal oxygen level may be 88% all the time. That's how they live, and that's where they live, and they usually can tell you that. If you've got someone that's got COPD and they know it, they know what their oxygen normally runs. Yes, COVID did cause low oxygen levels, yes, and we sent a lot of people home with oxygen tanks, let me tell you. Okay, so the last thing I want to say is I really want you to consider, if you want to know more about this stuff, if you want to learn more, volunteer for your fire department, your local fire department. Let me tell you some reasons why. It's great reconnaissance for your local area. You learn what's going on around you. You learn where the drug houses are. You learn where the good area of town is. You learn all about this stuff. So it's good reconnaissance for your area. It's great orientation for your local geography. You learn where the back roads are and how to get through them. It's great education for medical and fire skills. It's a great way to meet others and be active in your community. I really encourage anyone who's got an interest in this to do it. Take a first responder or EMT course. If you're a part of a MAG, someone in your MAG should do that. But never stop learning. We've given you a lot of resources to learn with, and I hope you will use them and learn more. I learn something new every day if I can. Thank you very much. Yes.
Thank you, Carol.
Hey, real quick, you started to talk about stroke. Do you let everybody know what the signs of stroke are?
Sure, you do fast. So, signs of a stroke are facial drooping. You have one side of paralysis, sometimes the inability to speak, depends on which side of the brain is affected. And so it's face, arms, speech, time. So fast. Face, they have facial drooping. Arms, you have to hold their arms out like this. Someone who's had a stroke, their arm will drift. They can't hold it up. And speech, you have them say the sky is blue in the Ozarks, and they can't say that. If they say that's what it comes out as. So those are signs. And time is essential. These ERs now have the ability to give a medication that will reverse a stroke if it's done quickly enough. So it's also important that you know what time the symptoms changed. When were they last seen normal? That's what we asked. When was the last time you saw them normal? And if it's within this certain window of time, they can do this reversal of the stroke. Same thing with a heart attack, by the way.
A UTI can mimic a stroke sometimes.
Lots of things, yes. UTIs can, especially in the elderly.
Yeah, my mom was talking slurred.
Yes, yes. And sepsis will do that too. It's usually, it depends on the neuro doctor, but it's usually about 6 hours.
I have a quick question.
Sure.
Your thoughts on the choking, somebody's choking,
The Heimlich?
well, no, this choking device.
Oh, really, I can't really judge that choking device. I've heard some things about it, and I've seen some articles about it. I haven't used it myself. There have been some people that have been saved because of them, but I don't have enough information to really address that. I don't think it hurt. Anybody else? Yes.
What do you do, what do you want to do if someone has, they show symptoms of a stroke, but can't get to a medical facility where it's
There's not a lot you can do.
Is there any of that medicine that you were talking about that they can administer?
No, that is very, very specific, and has to be given in a certain way, and you have to have a neurologist to authorize it. When I worked in the ER in Lebanon, we would have a neurologist on the phone that would talk to the patient and examine the patient by having them make certain movements and such, and find out the information, look at the patient's chart, and then make the decision whether or not they were going to get it. Yeah, a stroke, unfortunately, the stroke, if the damage is done and they're not able to get that, it's done. The damage is done. Is that all?
Questions? Okay, thank you, Carol and Mike. Very good.